Yeah.
Okay, so, well, good afternoon and good evening, everyone. Gives me great pleasure. Thank you very much for attendance, and also thank you much to Diagnexia for their continued support of this program. So, great pleasure this afternoon to introduce a colleague of mine, Professor Runjan Chetty. He really needs no introduction in the international field. He's a very experienced anatomical pathologist. His specialist interests in GI and pancreatic pathology. He's also got an interest in the mechanism of tumorigenesis. So he's held chairs in South Africa, in Glasgow, in Toronto, in Oxford. He's been head of pathology at Brighton and Sussex. He's presently Chief Medical Officer at Diagnexia. So he's continuing to support diagnostic pathology around the world. And more recently, Diagnexia and Deciphex are also supporting teaching of pathology around the world. So we're very grateful to have him, given his the many demands on his time. Today he's going to be talking on inflammatory bowel disease. Thank you very much, Runjan. I'll pass over to you.
Thank you very much, Richard. And it's my pleasure to participate in your series. I think this is a major contribution to education and really provides something that there is a definite need for. So I don't know if any of you attended my initial talk, which was on miscellaneous colitides. And one of them was, I mentioned, was inflammatory bowel disease. So the basis of this particular talk is to go through some of the basic facts that we know about inflammatory bowel disease in terms of the pathology, and then I'll dwell a little bit more on the recent developments and some of the diagnostic conundrums that face us as diagnostic pathologists. Inflammatory bowel disease, or as it's known, idiopathic inflammatory bowel disease, spans three different diseases, as we all know: Crohn's disease, ulcerative colitis, and what was called indeterminate colitis, which was sort of in between, where we couldn't quite make up our minds. It is now called idiopathic inflammatory bowel disease unclassified, or IBDU, and you'll see that abbreviation cropping up in the literature. And in its obvious form, Crohn's disease and ulcerative colitis, we know in their classical forms, can easily be distinguished because they have a set of features that allow them to be clearly delineated. However, there are a growing number of cases where there are areas of overlap. And this is especially true when we get biopsies, because biopsies really don't give us the full panoramic view of what's going on in that particular bowel. So biopsy pathology in IBD can be quite complex and difficult to separate. And really, my advice right up front is don't pigeonhole yourself. Don't be forced by a gastroenterologist into making a diagnosis of Crohn's or ulcerative colitis if it is not diagnostically clear, because it'll be held against you, and they'll implement the wrong treatment and they'll say, well, pathologists called it Crohn's or ulcerative colitis, when actually all you could say was IBD, and they need to do clinical and endoscopic correlation. Now, indeterminate colitis, or IBDU, is really a diagnosis that's made on resection specimens by us as pathologists. The clinicians often query it because they can't distinguish between Crohn's and ulcerative colitis based on the clinical and endoscopic appearances. I rarely make the diagnosis personally, because generally you can really put it into either Crohn's or ulcerative colitis, and it's only when you really cannot then use IBDU. I would suggest don't use it as a sort of waste paper basket category. The incidence in Western countries of IBD is certainly increasing. It's 14 per 100,000 individuals, and it's really going up. And the most recent one was 240 per 100,000 individuals in certain countries. So depending on where you do the survey, it's certainly a very real, very common disease. And it is worldwide. So irrespective of where you practice, and I know there are certain other diseases that can mimic it that should be excluded, i.e. in the infectious range, but certainly it's something to be aware of. And it's estimated that there are about 7 to 8 million cases diagnosed across the world. Now, Crohn's disease tends to affect females who are smokers, younger patients, 15 to 40, whilst ulcerative colitis, there is no real gender predilection. It's more common in non-smokers, and all age groups are at risk. The etiology is multifactorial, and you can see I've got a list of items there, and they probably all contribute to greater or lesser degree in any particular individuals. There is a genetic a suggestion of a polygenic disease, which occurs in 1 to 16% of patients with IBD, because they have seen the similarity in twins who share HLA makeup. In Crohn's disease in particular, a so-called IBD gene has been identified on chromosome 16 called NOD2, and this has been dysregulated in a proportion of patients with Crohn's disease. It is not pathognomonic. Whilst patients with ulcerative colitis have aberrations on chromosome 7q and 22q. A very powerful influence in the genesis of IBD is environmental and psychosocial issues, stress and gut infections, diet and cigarette smoking, as I've alluded to already, are very important in the pathogenesis. And you know that certain psychological profiles have been built of patients who are classically Crohn's disease and ulcerative colitis. They tend to be very introverted, stressed, and they have that particular personality type. An important factor as well are immunological factors, because at the end of the day, it is an immune response. And there are unknown factors that trigger this immune response, that produce this inflammatory response in the bowel. And then there's a residue of cases where none of the above apply, and they are truly idiopathic. It just happens. So none of the patients don't have any of the well-defined factors that are associated with it. But just to summarize, that it is generally a multifactorial disease with multiple of these factors playing a role in the etiopathogenesis. The symptoms vary depending on the site of involvement, and it's characterized by relapses and remissions. And classically, patients present with diarrhea, dehydration, fatigue, etc., that are well recognized and well known. And many present with features of the nutritional disorders as a result of the diarrhea and PR bleeding in iron deficiency, B12 deficiency, folate. Younger patients tend to have growth retardation and delayed puberty, early onset osteoporosis, etc. And these are all just sequelae from the fact that the gut is not working properly. And then we know that there are extra intestinal manifestations involving joints, the eye, skin changes, and primary sclerosing cholangitis, which is an important consideration in the management of these patients. From a diagnostic point of view, we have 4 key modalities. Now, fecal screening is very common these days, and they screen for calprotectin. Imaging, everyone who has any abdominal pain now has imaging, and CT and MRI are very important diagnostic modalities. Endoscopy has really advanced, as I mentioned in my previous talk, with various techniques of chromoendoscopy and white light endoscopy, etc., that allow visualization of the bowel wall much better than it ever was. And finally, histopathological assessment. And histopathology really is the gold standard, as I've said down there at the bottom. It is the most effective modality in making the diagnosis. We as pathologists, therefore, hold the key to what the diagnosis is. So the role of the pathologist in pathological evaluation of biopsies taken in patients with questionable IBD is to establish a baseline diagnosis and exclude other treatable causes, such as infections. I can refer to 2 vivid cases that I had, one in Canada and one in the UK, where these patients were treated for months on steroids because of a clinical diagnosis of IBD, and no biopsy was done. Eventually, when no response was being seen to medical treatment, they decided to do endoscopy and biopsy, and lo and behold, it was amoebiasis in both cases, in both locations. So people travel, and the history isn't always elicited. So always be aware in cases that come in with a strong clinical history of IBD. Keep your thinking hat on and think laterally and exclude other treatable causes. Because they do a series of biopsies, it's up to us to determine the extent of involvement, given the differing sites that are biopsied, the severity of the disease, whether it's active and how active it is, whether it's quiescent, so chronic healing, or whether there's actual restoration to normality and the patient is in remission. And a very important, and probably the most important thing that we can do as pathologists is to assess for dysplasia, and I'll discuss that in greater depth later on. The other fifth reason why a biopsy is done is to monitor the response to treatment, to see if the patient is healing and in remission. So the goal is complete mucosal healing. Now let's dispense with indeterminate colitis, or IBDU. It's reckoned that 5 to 10% of cases with colitis that is idiopathic cannot be classified neatly into ulcerative colitis or Crohn's. Usually it's the clinician who makes the suggestion, and it is a term used by them quite frequently when they can't make up their minds. When we get the biopsies, invariably, and if it's representative and clear-cut, we will make their minds up for them. And sometimes we use it on resection specimens where we can't see definitive features for either. And that's the restricted use of the term IBDU that I would suggest. You look at a resection specimen and take multiple sections, and then at the end of the day, you cannot categorize it into either Crohn's or ulcerative colitis, then use IBDU. It is a clinical entity because it determines whether the patient will be selected for surgery. So it's not a throwaway term, so use it cautiously and use it advisedly. The gross pathology is well known to both for both ulcerative colitis and Crohn's disease. They're very classical, and Crohn's disease is a segmental disease that goes from mouth to anus. Sometimes you can get rectal sparing and classically skip lesions, and you have intervening normal mucosa between diseased mucosa. The ulcers are deep and penetrating. It's a full thickness transmural inflammation, and the surrounding mucosa to the inflammation becomes edematous and swollen, giving rise to this cobblestone appearance. I'll demonstrate that in a minute. And the entire thickness of the bowel wall is involved, hence it's given this hose pipe-like appearance. It's very thick and inflexible looking. And here is an example of Crohn's disease. As you can see, the bowel wall is very thick. There's adherent fat, mesenteric fat, and you have this sort of raised, heaped edematous lesions in between, imparting this cobblestone appearance, the ulceration going, fissuring deep, and here's more ulcers. And importantly, you've got an area of involvement, and then less involvement, and then normality, and then more normality. So these skip areas are quite characteristic if you look at it quite closely. Again, this upper section showing the thickness of the entire bowel wall, the adherent fat, and very, very cartilaginous appearing in certain parts of the mucosa of the bowel wall, I beg your pardon, resembling what you'd get in diverticular disease in some instances. But again, this very, very characteristic appearance, and again, you can appreciate the cobblestone appearance of the edematous mucosa there with these lumps, and then ulcerated mucosa there. Ulcerative colitis tends to be localized at the colon and rectum, so it's a large bowel disease. And the lesions tend to flow into each other, and hence they're contiguous, so it causes a pancolitis. The exception being the so-called backwash ileitis, where the ileum is involved when the cecum and ascending colon is involved by ulcerative colitis. The mucosal inflammation here is diffuse, and it's as if a rake has been taken along the mucosa of the colon. It is superficial, but tends to be hemorrhagic and has a granular appearance. A reactive change with pseudopolyps or inflammatory polyps, imparting a seaweed appearance where the surviving mucosa overgrows and compensates for the ulcerated lost mucosa, is also a very characteristic gross feature. And I think if one pays enough attention to the gross examination of these specimens, and indeed any specimen, it really makes microscopic interpretation that much easier. And I think the importance of grossing or trimming of specimens is undervalued in training today. And I think if trainees spend more time on this, it certainly would make microscopy that much easier. And here's some examples of pseudopolyps that are present in a patient with these hemorrhagic pseudopolyps here. Look like worms in the colon. And this is a case of ulcerative colitis. So again, very characteristic appearances, sort of confluent superficial ulceration. You'll notice that the bile wall is not particularly thick and is of normal dimension, in contrast to Crohn's disease. And as I said, when it's in its full flower, the difference between Crohn's disease and ulcerative colitis is very easy to make. Similarly with microscopy, again, you will see the discontinuous involvement of the bowel, depending on where the biopsies are taken from. Transmural inflammation can't be appreciated really on biopsies. And again, you're very dependent on the clinical information here. If one sees microgranulomas, again, not related to ruptured crypts, again, be very careful not to mistake cryptolytic granulomas for microgranulomas that are seen in Crohn's disease. And oftentimes, this is an obvious example, but oftentimes they're much, much smaller with 5 or 6 epithelioid histiocytes, which are clustered together. When you get resection specimens, I think then the diagnosis is really quite easy because you see it is a transmural disease. You have prominent lymphoid aggregates which stud through the submucosa, imparting this rosary bead appearance, and you have adherent fat and transmural inflammation, as you can see. But lymphoid aggregates and neuronal hyperplasia are all seen in good-going Crohn's disease. Ulcerative colitis, on the other hand, again, you need a resection specimen to see the full extent of the lesion. And here you can see there is submucosal sparing and the ulceration inflammation is up in the mucosa. So it's a superficial inflammatory process. And that's active, as you can see, with exudate and ulceration of the surface mucosa. And here's a more healed example. And here again, there is no restoration to normal. You've got misshapen crypts and glands. And again, do not be foxed to call this a sessile serrated lesion. You've got to know the history and the context in which you are interpreting your biopsies. So non-specific findings such as crypt abscesses and cryptitis can be seen in both ulcerative colitis and Crohn's disease. So again, the extent of the lesion and the context are important when confronted with non-specific responses by the bowel. Remember, again, I said in my last talk that the bowel has a limited repertoire of responses to injury, irrespective of the cause. Now, in terms of, just move this, the activity indices that are seen in patients who have got ulcerative colitis or inflammatory bowel disease, you'll know that there are several systems that have been put forward in terms of trying to quantify this. And some people have asked, some gastroenterologists have asked for this in routine practice. However, there are no universally accepted reporting systems of the several that have been published. And these are used mainly for clinical trials. And being involved in clinical trials in my current position, this is a request we get from the pharma industry frequently, is to use multiple scoring systems so that they can gauge the efficacy of the drugs that they've been using in patients who go into their clinical trials. And it's not usually used in routine practice. However, there are some gastroenterologists, and I've worked with them, who ask for this. And it is quite simple that they are published and the criteria are there. There are several reasons also for the lack of uptake of standardized reporting of activity in IBD. And it's time consuming because there are several parameters. There's several parameters that need to be quantified. And in some cases, the scoring takes a while to do. And interpretation really does muddy the waters here. The lack of reproducibility within yourself and between individuals who are doing the scoring is quite evident. And therefore, even in the clinical trials environment, they get 3 or 4 pathologists to score and look at the consensus score when accepting the final decision. And as I've alluded to already, the absence of widespread clinical utility in the context of using these scoring systems is not widely accepted as well. And as I said, although many have been suggested, they've been refined, and weighting to various parameters have been given to make them more clinically relevant. But despite this, it hasn't been widely taken up. One of the most important developments recently is that these scoring systems and indices correlate very well with what the endoscopist sees and the calprotectin levels that are detected in the patient. The three main scoring systems that, and there are several, as I've mentioned, that are used in clinical trials are the Gebo's scoring system, which has been modified and simplified a little, the Robarts histopathology index, which involves quite a bit of calculation and some higher mathematics, whilst the Nancy index is the simplest because it just assesses three parameters and scores three, that is acute inflammation, chronic inflammation, and ulceration, and then you provide a score on that basis. And as I said, it is not in routine diagnostic practice. However, it may crop up from time to time, and depending on your gastroenterologist and the clinical scenario in which they require that particular information, but just be aware of it. The complications of Crohn's and ulcerative colitis are also well known, and just listed in there for completeness. The one that I really want to dwell on, and is the crux of the talk, is the dysplasia carcinoma sort of complication that is really critical, especially in patients with ulcerative colitis. Let's dispense with Crohn's disease initially. The incidence of dysplasia is less. It only occurs in 2 to 16% of patients. And patients with Crohn's disease have a 2 to 5 times risk of cancer over and above the non-IBD population, so the general population. The patients who are particularly at risk are those who are under the age of 30, i.e. early onset inflammatory bowel disease or Crohn's disease, hence longevity of the disease, which destabilizes the colonic mucosa, hence leading it to be more susceptible to developing dysplasia and carcinoma. But the one of major importance is in ulcerative colitis. And in a patient who's had the disease for 10 years, there's a 2% increase, 2% risk, I beg your pardon, of dysplasia and carcinoma. And this goes up reasonably exponentially, 8% after 20 years and 18% after 30 years. And so if a patient is diagnosed with ulcerative colitis at a young age, one has to be vigilant in terms of the surveillance and looking out for dysplasia. And as a pathologist, this is where we earn our crust really in making these diagnoses. The risk of cancer in ulcerative colitis patients after a decade and a half, 2 decades or 3 decades is up to 45% in some cases. And the risk increases 1 to 2% after the first 10 years of diagnosis. So it is a very important feature that accompanies the diagnosis of ulcerative colitis. In terms of the assessment of dysplasia, and this is important from our point of view as pathologists, there's this group called the Surveillance for Colorectal Endoscopic Neoplasia Detection in Inflammatory Bowel Disease, the International Consensus Guidelines, that goes by the euphemism of scenic. And this has really empowered the endoscopists because of the advances that have been made in endoscopy, chromoendoscopy in particular. And based off of their guidelines, they can make diagnoses which influence the way patients are managed. However, it is a very brave gastroenterologist who will make the call purely on the endoscopic findings rather than getting pathological evaluation of the biopsies as well. And so I've put the asterisk there because this particular surveillance protocol really correlates with endoscopy, and I'll show you how the flowchart works in a minute. And when we do get the biopsies, we need to be very cautious because the endoscopist will suggest dysplasia. And oftentimes they are correct, but equally they may not be correct. And one of the problems with the assessment of dysplasia in IBD is that there is tremendous inter-observer variation, and not to mention observer. Very similar to what happens in Barrett's esophagus. We look at the thing and say, oh, we have this low-grade dysplasia here, put it away, come back the next morning and say, oh God, what was I thinking? So I think that really also prevails with assessment of dysplasia in IBD. If you're in any doubt, take deeper sections, show to a colleague. And one of the sort of caution mantras that I advocate is that if there's active inflammation, so ulceration, acute inflammation, transmural acute epithelial cells, etc., and you are umming and ahhing, back away. Do not make the call of dysplasia. Ask for a repeat biopsy. Unless, of course, it is clearly obvious. And there are cases where there is obvious dysplasia concomitant with acute inflammation and ulceration. So again, keep your wits about you when making the call. Usually the dysplastic areas are very clearly segregated from reactive and normal areas. It's almost like a night and day phenomenon, very, very analogous to what happens in Barrett's esophagus as well. But as I said, try not to be influenced by reparative change. When there's ulceration and acute inflammation, the nuclear changes have every reason to look the way they are. It's because they're being irritated, so they do react. And here's the sort of protocol that scenic guidelines provide for endoscopists. And again, it's really, again, due to the advances that have been made in endoscopy and chromoendoscopy. So if they have a look at it down the endoscope and there's no dysplasia, then the patient really can be individualized on current recommendations, and they come back every 6 months or 12 months or whatever they decide. If they think it's indefinite for dysplasia, treat any inflammation that is noted, which again is sometimes the cause for indefinite dysplasia. I generally don't use the term indefinite for dysplasia if there's good going ulceration and inflammation present. Again, in Barrett's esophagus, indefinite for dysplasia has been used by many in the presence of ulceration and acute inflammation, and this indefinite for dysplasia here alludes to that particular scenario. As I said, if there is ulceration and inflammation, there's every reason why the bowel looks the way it is. Say it is inflamed, ask for a repeat biopsy, because indefinite for dysplasia is a cop-out, in my opinion. It really should be reserved for when you cannot really make up your mind and there is no reason why the nuclei look the way they do. So treatment of inflammation, if inflammation is the cause for indefinite for dysplasia, and then they advise chromoendoscopy after a period of 6 to 12 months, again, depending on the individual patient. And the distinction between polypoid and non-polypoid is important as well, because polypoid dysplasia endoscopically has a better prognosis than non-polypoid. So therefore, they have slightly different protocols in terms of what they advocate. Clearly, if there's high-grade dysplasia, colectomy is still the treatment of choice in this particular scenario, because the patient would have failed medical treatment leading up to high-grade dysplasia. An interesting new dimension to this is the presence of multifocal low-grade dysplasia. And this again, if there's multifocal low-grade dysplasia, colectomy is a consideration in these patients. And again, it is dependent on the age of the patient and other risk factors. So it's a clinico-pathological decision. So again, usually they biopsy suspicious areas, but when they do a whole colonic series, you have to be vigilant for the presence of multifocal low-grade dysplasia in any of the fragments that are submitted. And this has considerable implications on patient management. And then non-polypoid, again, it depends on whether it is multifocal or unifocal, and that will influence whether the patient is followed up or has a colectomy. And there's this term right at the top there called invisible dysplasia. That's invisible to the endoscopist. And if they're worried, then the patient should be referred to an IBD center and the whole process repeated with biopsy, I might add. These recommendations have been refined depending on where practice is carried out. So there's geographic variation on the interpretation of these. The British Society of Gastroenterology has a version of their own based on local practice. And not only is it geographically defined, it is also institutionally defined, dependent on the GI surgeons and the gastroenterologists who practice locally. Okay, so getting down to the meat of what we do as pathology is to diagnose dysplasia. Now, it's now been divided into two forms. The conventional dysplasia, which we all know about, this is recapitulating what a tubular adenoma looks like, or tubular villus adenoma, so-called adenomatous type dysplasia, which we are all very familiar with and is by far and away the commoner type of dysplasia one encounters. However, recently, and I would refer you to this excellent review by Kristen Stachak and her colleague from University of Pennsylvania that appeared in the Journal of Clinical Pathology on so-called non-conventional or unusual or uncommon forms of dysplasia that actually one does encounter reasonably frequently. And looking back on my own practice of this, we've kind of ignored it because we've only been looking for conventional dysplasia. But certainly the non-conventional forms are really important and are present not infrequently, not as commonly as the conventional, but certainly something that you will encounter if you get a large number of IBD cases. Now, the term dysplastic adenoma-like mass lesion has been expunged from the literature, and the scenic guidelines that I alluded to initially has recommended that this term no longer be used, and it's now been called polypoid low or high-grade dysplasia. So non-adenomatous dysplasia and adenomatous type dysplasia, adenoma-like dysplasia, I beg your pardon, should be, you should not use that term. So if it's polypoid, you say low-grade or high-grade dysplasia, depending on what it is. And there are a couple of reasons why they've decided to dispense with this term down. Because the distinction between sporadic adenoma and IBD-associated polypoid lesions is unreliable. There is no reason why an IBD patient who is 70 cannot get a sporadic tubular adenoma. Therein lies the confusion in that particular reason. And continued surveillance may not be appropriate if, for instance, the lesion is completely excised and if it was polypoid. So depending on the scenario, that you make the call. If you say it's a sporadic tubular adenoma, then the patient will not be followed. However, if you say it's a polypoid low-grade dysplasia, then the patient will follow the surveillance as per IBD guidelines. So don't use the term down, use polypoid low or high-grade dysplasia for a lesion that looks like that. So looking at some of the images, this is a conventional dysplasia that we are all familiar with. Again, you can clearly see here that this patient has got IBD because there's architectural distortion, irrespective of the fact that these glands are dysplastic. And you can see that the dysplastic glands have pencillate nuclei, reminiscent of what you'd get in an adenoma. And the process extends right up to the surface. And again, here as well, you can see that the process goes up to the surface. And unfortunately, in this particular section, I can't show you the sharp demarcation between dysplastic and normal mucosa. It's because it's cut off. And a disclaimer here, these are images from that review that I shared with you by Kirsten and company. But again, you can see clearly that this looks like an adenoma. Here it's goblet cell rich, it's a bit villous. And again, even here, you will see that there's dysplastic change. Here it's a little bit more subtle. The epithelium is more eosinophilic. It's not as hyperchromatic looking, but you'll see that there's stratification and hyperchromasia, as well as pleomorphism within the nuclei. There's a smattering of acute inflammatory cells here as well, and you can see that in this bottom fragment here. But clearly, the nuclear changes outstrip the amount of inflammation here. And despite there being subepithelial inflammation, I feel quite confident to say that there's dysplasia here, irrespective of the fact there's a degree of acute colitis superimposed on it. This is the P53, and the P53 really has been a revelation, especially in Barrett's esophagus, but can be used and deployed in IBD as well, because mutant expression, and by mutant expression, I mean really dark brown nuclear staining, not just a blush. And even this in certain parts is a little bit difficult to interpret, but when it's dark brown and obvious in the areas of suspicion, you can feel confident that there is dysplasia there, low-grade dysplasia. So I would recommend the use of P53 in these scenarios where you have some inflammation and you're really questioning whether there is concomitant dysplasia. Do the P53, and if it's really dark and strongly positive, you can feel confident that there is dysplasia. Now, moving on to the unconventional forms, or the less commonly seen. And the first one is serrated dysplasia. And here it looks just like a sessile serrated lesion with dysplastic change. The crypt architecture resembles that of a serrated lesion with basal crypt dilatation, boot-shaped glands, and this horizontal fanning out as the base of the crypt hits the muscularis mucosae. And then related to this is and I'll demonstrate this in a minute, is the TSA-like areas. It looks just like a traditional serrated adenoma. The difference here being it is a patient with IBD. And otherwise, independently, if you were shown this, if there was no inflammation, you would not be able to distinguish sporadic lesions that look like this from non-sporadic. So if you're fortunate and you get other bits of the biopsy that have IBD, then you can feel confident in making sessile serrated like adenoma changes or dysplasia, as well as TSA-like changes in a patient with ulcerative colitis. So again, the history is really important. These serrated dysplastic lesions tend to occur in older patients with UC. This is what it looks like. Again, from an architectural point of view, you'll see this horizontal fanning and boot-shaped glands and serrations going all the way to the bottom and dilatation. And here it looks very much like an adenoma, except that we know the background has a bit of inflammation, and I know the patient has the history. Again, you've got this sort of serrated appearance, dilated base crypt there, background IBD. And this particular one looks for all the world like a traditional serrated adenoma with the deeply eosinophilic cytoplasm, elongated nuclei, and these flat-top mushroom-shaped serrations that typify a TSA. So these are the serrated type of dysplastic changes that one can see in IBD. And if you look away from that particular area here, you'll see that the epithelium here looks very different. It's got goblet cells in it. It's got more conventional type dysplasia. And it's important to remember that conventional and non-conventional can coexist. And as I said initially as well, if we got a mixture of lesions like this, my attention would have been directed clearly to the obvious conventional areas of dysplasia and ignoring the non-conventional. But if you look in some of these cases, you'll see that both coexist. The second, and this is a really tricky lesion, and I've seen this many times in patients with the UC, is this hypermucinous dysplasia. And I dare say I may have missed a few in my time. And this is characterized by abundant extracellular mucin, as well as mucinous cells with minimal nuclear atypia and this sort of very low-grade dysplastic change. And oftentimes they can be mistaken for regenerative or inflamed mucosa. And the other very important thing to remember, and I mentioned it in the last image that we looked at, it can coexist with conventional dysplasia and adenocarcinoma. So look around. You'll find conventional dysplasia, which makes it a lot easier to label the biopsy. But look around for the non-conventional forms as well, because they are often there. Again, out of context, a biopsy like this, you wouldn't call dysplasia because you don't know the clinical scenario. But in a patient with inflammatory bowel disease, this takes on more serious connotations. So again, you'll see, if we start at the bottom, you'll see that there's nothing here that really would alarm you. It's all basally oriented nuclei, lots of apical mucin, architectural distortion, sure. But this has been shown to be a form of dysplasia in IBD. And the closer magnification and different areas here, again, you'll see there's a degree of hyperchromasia, a little bit of obliquity of sectioning. But even if you look at the top here, you'll see that the nuclei are becoming to look a little bit more angry. Again, another very bland-looking lesion cytologically, but again, architecturally reasonably alarming, villiform in appearance, and mild stratification focally. But again, the background of architectural disarray and chronic inflammation. And here's the high power of that particular area there, and you'll see, again, nothing that would alarm you unless you are aware of the context of this and the slight hyperchromasia in the nuclei. But it's something to be really aware of, and look for areas with more conventional dysplasia, which may be comforting and really allow you to make the diagnosis that the entire lesion is made up of conventional dysplasia as well as hypermucinous dysplasia in other areas. Crypt cell dysplasia, or the basal crypt dysplasia equivalent in Barrett's esophagus, or I really like this term, surface maturation preserving dysplasia, because one of the mantras that we taught is that if there is dysplastic kind of change or cytologic atypia in the crypts or in the base, as long as it matures up to the surface, it is not dysplasia. However, there is now a little bit of a myth because of this entity of crypt cell dysplasia. So what's happening at the bottom, despite the surface looking fine and dandy, is important now. So you can't ignore the basal crypt changes in Barrett's esophagus as well as in IBD. And here the crypt cells have nucleatypia, but the surface appears normal, as is implied by the terminology. And in these scenarios, I always use P53, and P53 has come to the rescue lots of times. If, again, as I demonstrated in the image, the P53 is mutant and dark brown in staining, together with architectural disarray, you are well within your right to call it crypt cell dysplasia or basal crypt dysplasia, irrespective of the surface being normal. They tend to occur in flat dysplastic lesions rather than in polypoid. And again, as I said, it's very important to be aware of this particular entity and not miss it, because the patient will then be consigned to a normal surveillance protocol because of the surface maturation or surface regenerative change. So I think in the past, where we were taught that if the base of the lesion is showing dysplastic type change, as long as the surface looks okay, it's not dysplastic, is no longer true. And here are a couple of examples of it. And again, you'll see the P53 really is the critical feature here. While the surface epithelium does not show mutant production, these cluster of glands do. And these are the examples of what the glands will look like. And they're in isolation. It's a little tricky to extrapolate, really. But they can be minimally cytologically abnormal. But generally, you'll see that they cluster together. They have got hyperchromatic larger nuclei. And they look, if they were in any other location, you would classify them as dysplastic. If you get high-grade dysplasia in basal glands, look for adenocarcinoma lurking nearby. The next type of unconventional dysplasia that one can encounter is goblet cell depleted. Here, the glands are devoid of goblet cells. They look very much like conventional dysplasia, but they tend to be high-grade. And obviously, because they are high-grade, they're more aggressive and may harbor adjacent carcinoma. So absence of goblet cells typifies this particular form. And here are examples again. And you'll see that there is almost a reminiscence of two conventional. And you know, some of them, whilst these have been written in journals, you know, if you would call this conventional adenomatous dysplasia, not goblet cell depleted, I don't think anyone's going to raise any queries, because it is clearly dysplastic, whether you've got goblet cells or not. So again, some of these different types should be taken with a pinch of salt. I think you can clearly make the diagnosis here of dysplasia, irrespective of the type. And then just finally, just to finish off, Paneth cell rich, again, you've got a dysplastic lesion with loads and loads of Paneth cells, and they tend to confuse the issue because Paneth cells don't generally appear dysplastic in the setting of IBD. As I said, if you see Paneth cells, look again if there's a subtle dysplasia there. And then if you've seen colons that have had neoadjuvant chemoradiation and then they are resected, very characteristic oncocytic change is noted. They look very, very deeply eosinophilic. And look at the nuclear changes here, obviously in a patient with IBD. So there's no antecedent history of neoadjuvant chemoradiation. And in these areas, think of the so-called eosinophilic dysplasia. According to the review paper, these are under-recognized and less well-defined. And I don't think I've ever seen an obvious example of eosinophilic dysplasia. And dysplasia with signet ring features. So here you have cells in the glands or in the crypts that resemble signet ring carcinoma, but without invasion. It's almost like a hereditary gastric cancer in many ways. And again, if you see signet ring cells, be sure that they are true signet ring cells with nuclear atypia and not just goblet cells that look a little angry. And also just be sure before you call this this particular variant. I've seen a couple of cases of this. Again, if you see dysplasia with signet ring features, alert the clinician to the possibility of an adjacent signet ring carcinoma arising in inflammatory bowel disease. Okay, the message is, whilst I have, enumerated the 7 unusual forms of dysplasia, are they really practically important? Well, they are, because they are dysplastic, clearly. And if you have, and as I've alluded to already, conventional dysplasia that coexists, you're okay. But if you don't have conventional dysplasia, the message is to be aware of these histological nuances and variations. And as I said, P53 can help in making the diagnosis. So I think it's very important to be aware of it and stain, do extra sections, show to colleagues, because you do not want to miss low-grade dysplasia, especially if it's multifocal, given that colectomy is a therapeutic option. In terms of the behavior, clearly there's no difference in terms of progression to conventional carcinoma from either conventional or non-conventional. But the importance from our point of view is not to miss these non-conventional forms of dysplasia. I just quickly want to discuss a term that has hit the literature in pathology, the serrated epithelial change. Now, this I have seen frequently, is that the epithelium adjacent to IBD has this serrated appearance. And I've always ascribed it to being a reactive change. Now, whether it is serrated epithelial dysplasia or not is another question. And it is controversial, and not everyone has accepted it as a diagnostic entity. I have noted it in my report and said no obvious dysplastic change, although the glands look serrated. Adjacent to that is chronic active IBD or whatever it is, and negative for dysplasia. But again, this is a controversial lesion for the simple reason that a study has been done on serrated epithelial change, and P53 abnormalities have been found in them. Now, whether this attests to the fact that this is the earliest form of serrated dysplasia or not is a moot point. It tends to occur in the left side of the colon and rectum. Endoscopically, unfortunately, our colleagues can't help us. And it's only when we get to see this under the microscope that we make this call. Again, I think do P53, show it around, and be certain that there is no dysplastic change, and just describe it is my advice. Because later on, obviously, this may be shown to be a dysplastic lesion. So I'm just going to skip through some of these through what should you include in the surgical pathology report. So I think before you embark on writing a report, be aware of the clinical history, be aware of the previous biopsies and what they were called. It is prudent, especially if dysplasia or indefinite foot dysplasia has been called on the previous set of biopsies, to review them. I think you need to take the full temporal sequence into account, because whilst it may have been indefinite initially, there's no reason why 6 months later it is definitely dysplasia. So I think it's very important to review it and even look at it. The endoscopy now is really a critical piece of the picture that we need to be cognizant of, and therefore good correlation with the gastroenterologist and their findings is important. And again, I can't highlight enough a good working relationship between the pathologist and gastroenterologist in these cases. Take note of the sites of biopsies, and I know that there are hospitals which clump the biopsies into one cassette, clustering cecum top left and middle right is the descending colon, etc., etc. It's practice that I would certainly not advocate when looking at cases for IBD, especially if it's a colonic series. I would strongly advocate that the sites are separated into different pots and different cassettes. Take note of the number of biopsies. Again, it's important to make sure that it correlates with what the endoscopist has said and tissue is not lost or not cut through, and you need to go deeper. And then your examination, of course, needs to be very methodical and follow a sequence that a checklist that I use. Differential diagnosis. So if you don't get a clinical history, it could be anything. And, ranging from drugs to ischemia to chemoradiation and all the miscellaneous colitides that I did in the last talk come into play. And it's very rare today that we don't get the endoscopy report or a clinical history. So technically speaking, this is just there for completeness. I cannot imagine anyone practicing in a vacuum where they don't get adequate clinical history. Now, is the bottom line in your report the features I'm keeping with idiopathic inflammatory bowel disease? However, clinical pathological correlation is advised. I have used that. I'm not denigrating this as a report. It irritates the life out of the gastroenterologist because they feel when we get a report, they do correlate it, and you're stating the obvious. But by the same token, we need to be a little bit defensive sometimes, especially when we do not get an adequate history. If you don't get an adequate history, that is perfectly acceptable to put into the report, because at the end of the day, you don't know whether it is due to ischemia or infection or whatever it is, unless you see an organism, of course, and the clinician needs to correlate it. If you get a strong history and you've looked at the previous biopsies and read the report and you know that the patient is known IBD, then generally I don't put clinical pathological correlation is advised for the reason I mentioned. It kind of annoys them. Okay, I'll quickly go through management. Again, it's multidisciplinary. It's a full team in both Crohn's and ulcerative colitis. And there are a variety of medical forms of treatment, from nutritional supplementation to various drugs that work with amazing efficacy, especially the new immune modulators, where you can get absolute restoration to normal. These anti-TNF antibodies are simply amazing in terms of the recovery of the bowel. Endoscopically, of course, they do surveillance, and they also remove lesions as well. So that's part of the treatment, and many times polypoid lesions can be snared in its entirety. And of course, the ultimate surgical intervention, that of resection of the bowel, is dictated to by both the endoscopic appearance and our pathology report. Similarly, in ulcerative colitis, the same three sort of protocols are used, and especially in ulcerative colitis, these small molecules or JAK inhibitors are the new magic charm in the medical treatment of these patients, and really can defer definitive surgery later on. Okay, I think I'll stop at this point. We've got a few minutes for questions, and for those of you who are interested, it's the 3rd to the 5th, not 55th day in September. We have our Diagnexia Histopathology Symposium, and if you scan the code, you can register, and we'd be delighted to see you in Oxford, where we host the symposium every year. Thank you.
Thank you very much, Runjan, for that excellent talk. The background, I learned a lot from that. I was unaware of the link with psychosomatic factors and chronic stress. So that's probably quite important. And also going through the dysplasia, because I think that my understanding was that it's always there's a lot of focus, I think, in distinguishing ulcerative colitis and Crohn's on a microscopic level, and maybe not so much to all those different types of dysplasia, and also highlighting the importance of being involved in the cut-up or grossing of the specimens. I do think that gives you a lot of information, and I agree that trainees in our country, the UK, are being less exposed to that, and I think they're losing a lot from that. In terms of obviously dysplasia is going to be, patchy as well. So to what degree are the endoscopists kind of confident in the endoscopic appearances as which parts to biopsy?
Yeah, you see, chromoendoscopy has really revolutionized what they visualize, Richard. And because of the difference in color and the difference in appearance, they can really be very accurate in where they biopsy. So therefore, they do the series, it's the bane of our life when we get a series of 15 sets of biopsies of ×3 with 3 levels, etc. But actually, it is a service to the patient in doing this sort of mapping across the colon. And yeah, the chromoendoscopy is very, very good. And as I said, based on their findings alone, even without biopsy, they can direct management.
Right. And how important do you think? I mean, obviously, P53 is really important, but there may be lots of the parts of the world where it's not available. So to what degree do you think that confidence in diagnosis of dysplasia can be made without it?
In the majority of cases, yes, comfortably. It's really in those very difficult, is it indefinite or is it dysplasia, low-grade dysplasia, in the setting of acute inflammation or one of the more subtle unconventional forms. If you don't have P53, then I would say indefinite for dysplasia and get the patient biopsied again. If you're certain, if you are in that category and you feel you can push it towards dysplasia, then do so. If you're not, then say indefinite for dysplasia. If there's ulceration and inflammation, you would then say you've got ulceration and inflammation. Don't say indefinite for dysplasia in that scenario. There are other markers, and I ran through them in the talk. There's AMACR, there's Ki67, there are a variety of other markers that have been suggested, but I would not use them in routine practice because there are no parameters to say Ki67 of 44% means it's dysplasia. It's just purely a hand-holding exercise, and I would not do stains like that routinely because you have no handle on what to call and what not to call. It really doesn't help you. Regenerating and inflamed mucosa proliferates just as much as low-grade dysplastic lesions do. Yeah. And they have every reason to do that. So again, I don't advocate the use of proliferation markers in this scenario.
Okay, thank you. Are there any questions from the audience? It was well attended.